300 to 400 physicians die by suicide every year in the United States. That's roughly equivalent to 1 to 2 entire medical school graduating classes every year. Disappearing. And we almost never talk about it. Last episode, we introduced medical malpractice stress syndrome. What it is, how it manifests, and why the process of being sued can be more damaging than the outcome. Today, we're going deeper. We're talking about the intersection of MMSS and the physician suicide crisis. Because civil legal problems, including malpractice litigation, increase suicide risk by 61% in surgeons and 80% in non-surgeons. And the structures that should protect physicians from reaching that point are failing. This is part 2 of our 3-part series, The Silent Crisis. In 2020, Duarte and colleagues published a systematic review and meta-analysis in JAMA Psychiatry that examined physician suicide rates across 32 articles and 9 datasets. The findings were nuanced and, in some ways, surprising. Female physicians have a suicide standardized mortality ratio, or SMR, of 1.46 compared to women in the general population. That means female physicians are 46% more likely to die by suicide than non-physician women. Male physicians, by contrast, have an SMR of 0.67, meaning they are actually less likely to die by suicide than men in the general population. The authors note that this likely reflects the higher baseline suicide rate among men generally, not a lower absolute burden among male physicians. Both male and female physician suicide rates have decreased compared to pre-1980 data, but the absolute numbers remain staggering. An estimated 300 to 400 physicians die by suicide annually in the United States. That's roughly 1 physician every day.
I want to put that 300 to 400 number in context. That's more physicians than die from some of the diseases we spend billions of dollars trying to prevent. And the gender data is particularly important because it defies what most people expect. In the general population, men die by suicide at roughly 4 times the rate of women. Among physicians, that gap narrows dramatically. Female physicians have a much higher relative risk compared to their non-physician peers than male physicians do. But what I want physicians listening to understand is this: 300 to 400 per year is not an abstraction. That's your residency classmate. That's the attending who trained you. That's the colleague down the hall who seemed fine at morning report. Physician suicide is happening around us, and most of the time we don't know about it until it's too late, because the same culture that conditions us to project invulnerability makes us invisible when we're falling apart.
The most direct quantitative evidence connecting malpractice litigation to physician suicide comes from G and colleagues, published in JAMA Surgery in 2020. This was a retrospective cohort study examining suicide risk factors in both surgeons and non-surgeons. The key finding: civil legal problems, a category that includes malpractice litigation, increase suicide risk by 61% in surgeons, with an odds ratio of 1.61. In non-surgeons, the increase is even higher, 80%, with an odds ratio of 1.80.
That differential is important and initially counterintuitive. Surgeons face higher rates of litigation overall, so you might expect them to be more affected. But the data suggests the opposite. It's the physicians for whom litigation is less common who experience greater distress when it occurs. And the proposed mechanism makes sense. Surgeons develop a degree of professional normalization around litigation. It's not that being sued doesn't affect them. The MMSS data clearly shows it does. But they're more likely to have colleagues who've been through it, mentors who can contextualize it, and a specialty culture that, at least to some degree, acknowledges litigation as an occupational hazard. A family medicine physician or a psychiatrist may have no such framework.
And that's one of the reasons I think this topic matters so much for the charted defense audience. Our listeners practice across every specialty, and while it's the surgeons and the OB/GYNs who face the highest claim rates, it's the physicians in lower risk specialties who may be least prepared for the psychological impact when a claim does come. If you practice internal medicine or pediatrics or psychiatry and you get sued, you may genuinely have no one in your professional circle who can say, "I know what this feels like." And that isolation, combined with the MMSS response, is what creates the conditions for suicidal ideation.
A national survey of over 7,100 American surgeons examined the relationship between malpractice litigation and mental health outcomes. Among surgeons who had been involved in a malpractice suit within the prior 2 years, rates of recent suicidal ideation were 6.4%, compared to 4.0% among those without recent litigation. That's an odds ratio of approximately 1.64 after adjustment for practice and personal characteristics. The same study found higher rates of depression, screen positivity, and burnout among recently sued surgeons, suggesting that litigation involvement and clinician distress may be bidirectionally related, meaning being sued increases distress. But pre-existing distress may also increase malpractice risk.
That bidirectional finding is important because it tells us we're dealing with a feedback loop, not a simple cause and effect chain. A physician who is already burned out may be more prone to errors, communication failures, or documentation gaps that increase litigation risk. And then the litigation amplifies the burnout, depression, and distress. It's a vicious cycle. And the 6.4% suicidal ideation figure. I want people to hear that clearly. That's not 6.4% of a small, self-selected group. That's from a national survey of over 7,000 surgeons. And if you extrapolate across the physician workforce, the number of physicians with malpractice-related suicidal ideation at any given time is not trivial. These are our colleagues. They're going to work, they're seeing patients, they're functioning, because that's what physicians do. And inside, they're thinking about ending their lives.
The surgeon data comes from the United States, but the pattern is international. A large UK survey of nearly 8,000 doctors examined the impact of regulatory complaints on mental health. Doctors with current or recent complaints had elevated risks of moderate to severe depression and anxiety, and were approximately 2.08 times more likely to report thoughts of self-harm or suicidal ideation than those without recent complaints. And this is where the data becomes even more sobering. A 2014 internal review commissioned by the UK's General Medical Council examined deaths of doctors who had opened fitness to practice investigations between 2005 and 2013. The review identified 28 cases classified as suicide or suspected suicide, 24 confirmed suicides, and 4 suspected suicides.
The GMC review is significant because it provides the most methodologically rigorous documentation of the intersection between regulatory investigation and physician suicide. It's not anecdotal. These are cases reviewed with coroner records, internal documentation, and clinical context. The review found that many of the doctors had recognized mental disorders, depression, bipolar disorder, personality disorders, and some had substance use issues. But the investigators also identified contributing stressors that were directly linked to the investigation process itself. In one case referenced in the review, a doctor's note stated, and this is a direct quote from the coroner elicited context, "I am extremely stressed. I hold the GMC responsible for making my condition worse with no offer of help." In another, a doctor died by suicide before an interim orders panel review, and the coroner's inquest noted that a contributing factor was, quote, "a matter of a regulatory nature."
I want to pause here because these are not statistics. These are people, physicians, who went into medicine to help others, who ended up under investigation, and the investigation, with its delays and its uncertainty and its threat to their identity and livelihood, contributed to their death. And I'm not assigning sole causation to the regulatory process. The review is clear that these cases involved multiple stressors, but the investigation was a contributing factor, and that's something the profession and the regulatory bodies need to sit with.
A 2023 mixed method study from Australia added an important dimension to this picture. Researchers examined both practitioner interviews and a serious incident analysis of cases involving self-harm, attempted suicide, or death by suicide among practitioners who were in or had recently completed a regulatory complaints process. The study identified specific trigger points where severe distress clustered. These were not distributed evenly across the process. They were concentrated around 4 moments: the initial notification of the complaint, decisions about suspension, receipt of independent health assessment results, and referral to a tribunal.
That trigger point finding is critical from a systems design perspective. It tells us that the risk isn't uniform throughout the process. There are identifiable moments of acute vulnerability, and those moments are modifiable. The way a complaint notification is communicated, the timeline around suspension decisions, how health assessment results are delivered. These are all process variables that institutions and regulators can change. The study explicitly emphasized modifiable process factors: communication quality, timeliness, and tailored health impairment management.
What this study is really saying is that the system itself is a contributing factor in these deaths, and the system can be redesigned. We're not talking about eliminating accountability or ending regulatory oversight. We're talking about conducting investigations in a way that doesn't needlessly destroy the people being investigated. Sending a complaint notification by form letter with no accompanying support resources is a choice. Delaying a suspension decision for months while the physician sits in uncertainty is a choice. These are choices that can be changed, and the evidence says those changes could save lives. The literature identifies multiple structural and cultural barriers that prevent physicians experiencing MMSS-related distress from seeking mental health support. Michael, walk us through these. There are 6 that I think matter most, and they compound each other. The first is fear of medical board reporting. Many state licensing applications still ask about mental health history, not just current impairment, but past diagnosis and treatment. The AMA has taken a strong position on this, calling on state boards to stop asking about past mental health treatment and to focus only on current impairment. But implementation is slow, and the result is that physicians calculate a terrible risk-benefit equation. If I seek help for my depression during this lawsuit, will that information end up on my licensing application? Will it trigger a board investigation? Will treating my MMSS create a second professional crisis on top of the first one? For many physicians, the rational answer, or at least the answer that feels rational in the moment, is to not seek help. The second barrier is stigma within medical culture. We've talked about this in other episodes, but it bears repeating. Medical training selects for and reinforces traits like stoicism, self-reliance, and projecting competence under pressure. Those traits are adaptive in the clinical environment. You need them to function in a code, in a trauma bay, at 3 a.m. when you're the only physician in the hospital, but they become maladaptive when applied to your own mental health. Seeking therapy feels like an admission of weakness, and in a culture that rewards invulnerability, weakness is the one thing physicians can't afford to show. Third, confidentiality concerns. Physicians worry that mental health records will become discoverable in litigation, and in some jurisdictions, under some circumstances, they can be. This creates a legitimate legal concern layered on top of the cultural stigma. You're already being sued. The last thing you want is your therapy notes being read aloud in a deposition. Fourth, the defense attorney's advice to stay silent. As we discussed in Part 1, the advice to not discuss the case is about case details, not emotional impact. But many physicians interpret it broadly. They go silent on everything, the facts, the feelings, the fear, and they suffer alone for years. Fifth, failure to recognize symptoms. Because MMSS is a form fruste of PTSD rather than the full disorder, physicians may not recognize their symptoms as a trauma response. They attribute the insomnia to stress, the irritability to overwork, the avoidance to rational risk management. They don't realize they're experiencing a well-documented occupational syndrome until it's severe. And sixth, access and time. A physician in active litigation is typically still working a full clinical schedule while managing depositions, document review, and attorney meetings. Adding therapy appointments to an already impossible schedule feels like one more demand on a person who is already overwhelmed. And if you're in a rural area, as many physicians are, a therapist who understands both clinical medicine and litigation stress may simply not exist within a reasonable distance.
The barriers Michael just described are not new. A 2012 analysis by Lega in the Journal of Medical Humanities traced the history of physician suicide in America over an entire century, from the early 1900s to the present day. Lega identified a persistent pattern: the medical profession's emphasis on perfection, discomfort with vulnerability, and culturally reinforced silence around mental health has hindered comprehensive consideration of physician suicide for over 100 years. The golden age values of medicine, the image of the physician as infallible, tireless, self-sacrificing, created an identity that couldn't accommodate weakness, failure, or psychological pain. And those values, while evolving, have never fully been replaced.
Lega's work is important because it shows that this isn't a new problem. It's not something that emerged with modern litigation rates or electronic health records or corporatized medicine. Physicians have been dying by suicide, and the profession has been failing to address it for over 100 years. What's changed is not the problem. It's our willingness to finally name it. And even now, that willingness is uneven. There are institutions and specialties where talking about physician mental health is becoming normalized, and there are others where it's still considered career-ending to admit you're struggling. We are not where we need to be.
There's a systemic dimension to this that connects physician distress to patient outcomes. Sarah, can you walk us through the defensive medicine data?
The defensive medicine literature shows a clear pathway from MMSS to changed clinical practice. Vizcaíno-Rakosnik's survey data found that acknowledging a psychological impact from litigation was positively and significantly associated with defensive medicine practice changes, with a p-value of less than 0.0001, meaning the more psychologically damaged the physician is by the litigation, the more their practice changes. Those changes fall into two categories that the literature distinguishes. The first is assurance behavior. Over-testing, over-imaging, excessive specialist consultations, and meticulous record-keeping driven by legal fear rather than clinical necessity. A survey found that 42% of physicians with recent claims paid excessively more attention to record-keeping, and 36% began ordering more tests specifically for legal cover. The economic estimates suggest defensive medicine costs the U.S. healthcare system between $60 billion and $108 billion annually, which actually exceeds the direct costs of malpractice litigation itself. The second category is more dangerous. Avoidance behavior. That's the active refusal to treat high-risk patients, perform complex procedures, or take on cases with a high probability of adverse outcomes, regardless of the physician's capability or the patient's need. Up to 21% of physicians actively avoided specific types of patients after being sued, and nearly 20% stopped performing certain procedures entirely.
The practice changes they adopt, the avoidance, the defensive testing, the withdrawal from complex cases, represent a degradation of the care the system can deliver. Patients who need complex procedures can't get them because the surgeon who should be doing them has decided the risk isn't worth it. not the clinical risk, the legal risk. The net effect of the malpractice stress epidemic is that patients get worse care delivered by physicians who are more afraid and less engaged. The system that's supposed to ensure accountability is actively undermining the quality of care it claims to protect.
While the majority of physicians who face malpractice claims continue to practice medicine, over 90%, even among those with multiple paid claims, their professional trajectories are significantly altered. Research shows that physicians with severe MMSS often aggressively modify their practice environments to minimize future exposure, frequently leaving large hospital systems for smaller practices, solo practice, or non-clinical administrative roles. A notable percentage of physicians cite the stress of malpractice litigation as a primary catalyst for premature retirement. The withdrawal of experienced specialists from high-acuity surgical and obstetric roles represents an irreplaceable loss of critical human capital, exacerbating physician shortages and reducing access to complex care.
I see this in hospital medicine. Experienced physicians who have been through litigation become risk-averse in ways that reshape their entire career trajectory. They stop doing procedures, they stop taking the most complex admissions, they transfer to settings where the patient acuity is lower and the litigation exposure is reduced. And I understand that decision. I don't judge it. But the system loses something when a physician who spent 15 years developing expertise in critical care or acute surgery decides that the legal risk isn't worth it anymore. That's a system's failure. We trained that physician, we invested in that expertise, and the tort system drove them away from the patients who need them most.
One of the challenges in discussing the litigation-suicide link is that individual cases are difficult to document publicly. Privacy constraints, the multiple concurrent stressors present in any suicide, and the understandable reluctance of families to publicize the circumstances all limit public reporting. Organizations like Physicians Anonymous have documented specific cases of physicians who completed suicide upon first receipt of malpractice claims, after judgments against them, or after financially motivated settlements imposed by insurers. But most of these cases remain anonymized or known only within their local medical communities.
And I think that privacy is appropriate and should be respected. But I also think the invisibility of these deaths contributes to the silence. When a physician dies by suicide during active litigation, it's rarely reported that way. The family doesn't publicize the cause, the hospital doesn't announce the contributing factors, and so the profession never learns from it. We don't ask, what could we have done differently? Were there warning signs? Did anyone check on this person? Was there a peer support program? Was there a moment, a trigger point, to use the Australian studies language, where intervention could have changed the outcome? We don't ask those questions because we don't know it's happening. And that's the most dangerous form of silence, the kind where we don't even know we're being silent.
Michael, what should physicians take from this episode?
4 things, and I'm going to be direct because this topic demands it. First, check on your colleagues, not with a generic, "How are you?" with a real question. I know you've had a tough few months. How are you actually doing? If you know a colleague is in active litigation, they need someone to ask them that question. They probably won't volunteer the information. You have to go to them. And if they say they're fine, check again in a month, because they're probably not fine. Believe me, I know. Second, know the resources. The Physician Litigation Stress Resource Center, founded by Dr. Sarah Charles, exists specifically for this. The 988 Suicide and Crisis Lifeline is available 24/7. Most major malpractice insurers now offer emotional support programs. The Doctors Company, Coveries, MagMutual all have physician-specific wellness resources. A CEP has a volunteer peer support program for litigation stress. These resources exist, but most physicians don't know about them until they're in crisis. Learn about them now. Third, Advocate for change in your institution. If your hospital or medical group doesn't have a peer support program for physicians facing litigation, ask why. The RISE program at Johns Hopkins, the Mag Mutual peer-to-peer program, the Doohering group-based model from emergency medicine. These are proven, feasible, accepted by physicians, and effective at stabilizing burnout during litigation. They're not expensive to implement. What's expensive is losing a physician to suicide or premature retirement because no one reached out. Fourth, and this one is for you personally. If you are currently in active litigation and you are struggling, please hear me say this. What you are experiencing is normal. It has a name. It is a recognized occupational hazard. It does not mean you are weak. It does not mean you are a bad physician. And it does not mean you should handle it alone. Talk to someone, a colleague, a therapist, a peer support program, a crisis line. The emotional impact of litigation is not a case detail. You are allowed to talk about how you feel. Please do.
The physician suicide crisis claims 300 to 400 lives every year in the United States. Civil legal problems, including malpractice litigation, are a documented risk factor, increasing suicide risk by 61% in surgeons and 80% in non-surgeons. The barriers to help seeking are structural, cultural, and legal, and every one of them is modifiable. In Part 3, we'll shift from the crisis to the solution. We'll talk about what physicians can do before they get sued to protect themselves, the peer support programs that work, the insurer resources that exist, the cognitive reframing strategies that the evidence supports, and the policy changes that are beginning to address the structural barriers. Because the best time to prepare for MMSS is before it happens.
Here's the bottom line for this episode. Physicians are dying because of the stress of being accused of malpractice, not from the accusation itself, not from the verdict, from the process, from the isolation, from the silence, and we, the medical profession, have the knowledge, the tools, and the responsibility to change that. Every physician who dies by suicide during litigation is a preventable death. We need to start treating it that way.
If you or someone you know is struggling, the 988 Suicide and Crisis Lifeline is available 24 hours a day, 7 days a week. Call or text 988. This is the Charted Defense. Thank you for listening. This episode of the Charted Defense is for educational purposes only and does not constitute legal or medical advice. Medical malpractice laws vary by jurisdiction. Case details referenced in this episode are drawn from published, peer-reviewed medical literature and publicly available legal information. If you are currently experiencing a mental health crisis, please contact the 988 Suicide and Crisis Lifeline by calling or texting 988.